Olá, tudo bem? Boa noite a todos. Eu gostaria, então, de dar início ao nosso webinar de uroginecologia, então, Sogirgs pelo mundo. E, em primeiro lugar, então, gostaria de convidar o nosso debatedor, conhecido por todos, o Dr. Lucas Schreiner, que é mestre e doutor em gerontologia biomédica, professor da Escola de Medicina da PUC e presidente da Sogirgs, né? Bem conhecido de todos nós. Hoje, então, nós tivemos a honra de poder receber o Dr. Peter Dietz, que ele é ginecologista pela Universidade de Heidelberg, na Alemanha. Ele é uroginecologista titulado pela Royal Australian e New Zealand College of Obstetricians and Gynecologists. Ele é PhD pela Universidade de New South Wales, professor de obstetrícia e ginecologia na Universidade de Sydney entre 2008 e 2021, e ele atua com foco no assoalho pélvico feminino. Ele fez um vídeo exclusivo para a nossa sociedade, né, para a aula de hoje, e ele vai estar disponível para nós nos últimos 10 minutos da sessão para perguntas. Então, eu gostaria de reforçar a todos para usem o chat, encaminhem suas perguntas, que ele vai estar disponível para nos ajudar no que surgir de pergunta ao longo da apresentação dele.
Eu já estou com as perguntas aqui, quer dizer, com o papel e a caneta prontos. Boa noite, pessoal. É um grande prazer estar aqui com vocês em mais uma temporada de webinars da Sogirgs, né, Associação de Obstetrícia e Ginecologia do Rio Grande do Sul. Nós estamos já no nosso webinar de número 64, né? Começamos bem cedo com os webinars e não os abandonamos, né? Para que a gente possa levar, então, as informações nos rincões mais distantes, né, da capital aqui de Porto Alegre e também para fora do estado. A gente está muito feliz, muito honrado com a presença do Dietz com a gente. Ele fez questão de fazer a gravação anteriormente da aula, né, foi ontem mesmo que fez, e logo que acabar a apresentação, a gente volta nesse canal, então, aí a gente ficou com um canal exclusivo fazendo com tradução simultânea, que é um desses canais que vocês devem estar assistindo, imaginando que nós estaríamos falando inglês aqui, mas ainda não estaremos, né, voltaremos, né, na discussão, sim, para levar as perguntas de vocês para o professor, então aí ficamos com um canal em inglês e o outro com a tradução simultânea. Eu queria convidar todos vocês para se juntar à Sogirgs. Nós precisamos ampliar, obviamente, os nossos associados, né, já somos uma das principais associações dentro do Brasil, né, mas tenho certeza que temos um potencial maior, promovemos diversos eventos, os webinars, então, já são uma marca registrada, até pelo nosso pioneirismo, né, em relação a eles, e uma série de eventos presenciais, né, não posso deixar de lembrar vocês que agora em março a gente tem o nosso primeiro evento presencial do ano, dia 23 de março, o nosso Fórum Sogirgs, que esse ano vai versar sobre assuntos em reprodução humana. Logo em seguida, nós temos um evento específico para os residentes, né, que é os Caminhos da Ginecologia Obstetrícia, no mês de abril. No mês de maio, a gente vai subir para Bento Gonçalves, então, com mais um evento presencial, que é a nossa Jornada da Serra Gaúcha. Todos esses eventos estão lá disponíveis no nosso site, né, para vocês conhecerem quem vai estar participando, quais vão ser os temas, as aulas. Então, a gente quer que todos se aproximem da Sogirgs, que possam, então, se apropriar do conhecimento científico, debater em relação às suas dúvidas, e para que a gente possa manter a excelência dos profissionais, ginecologistas e obstetras do nosso estado e de todos os outros estados, então, que estiverem junto com a gente. Os webinars, então, seguem as outras atividades online, mas eu queria lembrar desses presenciais, e não posso deixar de falar no grandioso evento que nós vamos fazer em outubro, no Barra Shopping Sul, em Porto Alegre, que é o Congresso Gaúcho de Ginecologia e Obstetrícia. A gente conta com todos vocês lá, vai ser um grande evento e imperdível. Eu estou falando demais já, Marcelle, acho que eu não sou palestrante,
não, acho que tudo é verdade que o Lucas falou, tudo vale a pena.
Tá tudo na lei, né? Então tá. Pessoal, a gente volta logo depois da apresentação do Dietz, então, com ele ao vivo, para poder, então, esclarecer as dúvidas de vocês e desfrutar, então, dessa oportunidade de falar com um dos principais nomes, né, do ultrassom do assoalho pélvico no mundo inteiro, né, em termos de pesquisa, e um cara muito representativo dentro da Associação Internacional de Uroginecologia. Foi uma grande sacada a gente trazer ele, e eu tenho certeza que vai acrescentar muito na prática de vocês e no entendimento de todos nós em relação a ultrassom e assoalho pélvico, né? O que nós temos até o momento e para onde nós podemos ir. Obrigado.
Certo.
Hello, my name is Peter Dietz. I'm a urogynecologist in Sydney, Australia, and I'm supposed to explain to you, give you an overview of the role that pelvic floor, that is translabial or perineal ultrasound, can play in the investigation of urogynecological disorders. We'll have probably about 50 minutes talk, and after that, I'll be available for a Q&A on the phone, since this is a recorded lecture. I'm going to switch to the we're going to switch the presentation, please. Could we have the slides? And you should see the first slide now. This is an introduction. There are a number of aspects of pelvic floor ultrasound that really ought to be provided in more detail. And at the end, I'm going to provide a link to an IUGA online course that we've been running for the last 3 to 4 years. There's about 200 trainees so far, and we can provide teaching in 7 different languages. Now, why using imaging at all? Well, that's not a question that usually comes up in obstetrics and gynecology. It's obvious that imaging makes a big difference to practice, and it's not surprising, therefore, that it's also increasingly used in pelvic floor disorders. Because of access issues and because of cost, ultrasound is the most commonly used modality, and it's got rather major advantages compared to plain X-ray, CT, MR. Not just because it's simpler and cheaper and easier to access, it's also the only modality that allows true real-time imaging. That is the imaging of maneuvers. And it's also the best, clearly the best modality for the imaging of implants, slings and meshes. Now, imaging in urogynecology is almost exactly 100 years old. This is what's called the bead chain cystourethropy. And the first attempt at seeing the bladder and the urethra dates to 1928. In the 40s, that was enhanced by a chain of lead beads that was placed in the urethra, as you can see here. And then it was fluoroscopy from the 60s onwards. And for the last 20 years, there have been attempts to use dynamic MR to see what happens there. This is from John Delancey, and there's a state-of-the-art dynamic MR. So that gives you an idea of what can be done in the mid-sagittal plane and the temporal resolution and spatial resolution that can be achieved with MR. Now, we can do it much better, actually. MR is an inferior method when it comes to the pelvic floor for most of the applications that we're interested in. This is a list of indications. It's a little long. I guess the most important is that if somebody presents with urinary incontinence, with bladder emptying issues, with symptoms of prolapse, of obstructive defecation, or with trauma issues after childbirth, all these patients are likely to benefit from a pelvic floor ultrasound. Basic requirements are basically it's basically a machine that was built in the early to mid 80s. So a B-mode capable system, split screen facility is good. That was introduced in the early 80s. Xenoloops were introduced, I think, in the late 80s. Curved array transducers became commonplace in the 80s, and the video printer for documentation replaced the old Polaroids in the early 90s. So these machines, of course, if you try and buy such a machine used now, they are very, very cheap. This is how it's done. This was done, this particular slide, this is why the names are there. This particular slide was done by a trainee of mine in the Philippines, and we've had lots of contacts with the Philippines, lots of Filipino trainees. So you can see there's gel placed on the transducer, then a glove or a probe cover placed over the transducer, more gel, and then that gets placed on the perineum in the mid-sagittal plane. This is what you get as a result. There, on the standard image, which I apologize is upside down, but that's it's a historical artifact, because when we started doing this, there was no facility for flipping the screen. So you get the symphysis pubis here in front, then the urethra, the vagina, the anal rectum, the perineum, and above it you see the trigone and the bladder, the cervix and the uterus, the cul-de-sac if it's low enough, and the ampulla of the rectum. Now, the very first point to make there is that in order to assess both incontinence and prolapse, you need a Valsalva maneuver. You need a push, and that push has to be done properly. In the online course, and also when I teach people directly, face to face, the most important issue always is to get the patient to do a proper push. It's not like you need very high pressures, but at a pressure of 60 or 70, 80% of the maximum organ excursion is reached. What's more important is the time factor. It's a lot more important. And a lot of prolapse assessment is done with a short 2 or 3 second push, or even with coughs. It needs 5, 6, 7 seconds to reach 80% of maximum organ descent. And I guess that's not that hard to do when you're there with the patient, because if the patient is doing a Valsalva, a push, and you can still see the tissues move, you're unlikely to tell her to stop, isn't it? I mean, you want to see maximum organ descent. Otherwise, you'll end up with a false negative. We'll just demonstrate such a push. So the patient is at rest, and now she's starting to push. She pushes, and it takes a long time for that prolapse to come down all the way, because her hiatus is actually rather good. But she's pushing tentatively, and so far we have not really seen a prolapse. We're going to get her to push again, and eventually, hopefully, we'll actually see her prolapse. And there it is. So that's a cystocele. It's a 3rd-degree cystocele. There's also central compartment descent, which is harder to see on that clip. But I think you get the idea. Sometimes it takes a long time for a prolapse to develop. If the patient has symptoms and you can't see anything, you assume it's a false negative. You've got to get the patient to push properly, which is harder in women with a good intact pelvic floor, with a strong pelvic floor, and they sometimes have a prolapse too. And if you can't do it at all, if she cannot show you the prolapse at all, you need to stand the patient up, which I have to do in maybe 1 in 100 of our patients. The basic exam includes measurement of residual urine. That's really easy. You just need 2 diameters vertical to each other, and you multiply that by 5.6. It's in millimeters. So it's 5 by 5 centimeters, 25 by 5 is what, 125, 130 mils. The true wall thickness, the thickness of the bladder wall, is done on the dome. We take 3 measurements on the dome, and this must not be done if the residual is over 50, because then, of course, the trus are stretched and you get false negatives. Then there's bladder neck mobility and urine leakage. We look at urethral integrity, and we look at cysts and masses, in particular paraurethral, because that could be a diverticulum. Another clip, the patient does a Valsalva maneuver. She pushes and pushes and pushes and pushes. The bladder neck opens up. You can see that here. And that is the typical anatomy of stress urinary incontinence. So a bladder neck that looks like that, because, let's show that again. What's changed here is that the bladder neck has rotated downwards. It's moved about 3 centimeters, and the angle between the proximal urethra and the trigone has opened up, in this case, to about 170 degrees. There's also funneling of the bladder neck, which is the typical finding on stress urinary incontinence. Now let's go back to the situation at rest. You can see that the bladder neck is a long way above the symphysis pubis, which is here. And the angle between the proximal urethra and the trigone is about 90-100 degrees, and the bladder neck's closed. Now watch again what happens there. So there's about 3 centimeters of descent. The entire anterior vaginal wall rotates around the symphysis pubis, and the bladder neck opens up. This is the formal measurement. So there's the bladder neck symphysis distance, the position of the bladder neck above the symphysis pubis at rest and on Valsalva, and the sum of both gives you bladder neck descent, or BND. This here is the retrovesical angle between the proximal urethra and the trigone, which is about 100 degrees here and about 180 degrees here. And then you can also, if you want to, you can also measure rotation of the proximal urethra, which in a typical case, which in stress incontinence is commonly 70, 80, 90 degrees. In prolapse, it can be even more. You may have noticed that first clip that sister seal that didn't want to come down. Everything was kind of upside down, but that angle was still normal. Let's run another clip. So this lady surely has a sister seal because everything's folded up here. There's the bladder neck, and you can see the urethra very well. The trigone is this. There's the bladder neck. So that angle is intact. It's just in a very different place. And another thing that's interesting to show here is the interureteric ridge, which is the interureteric ridge. The interureteric ridge that's the trigone, and that lumpy bit here, that is the interureteric ridge, which stands out because that's the thickest, the most solid part of the trigone. So you can see that here. And if you wanted to, here, so about 2 centimeters from the internal meatus, and if you wanted to, you could you could run your transducer across and then see the ureteric orifices. Another valsalva, so this is the anterior vaginal wall. There's rotation of the urethra around the fulcrum of the symphysis pubis. And the interesting point here is that there's marked urethral funneling and the retrovesical angle is gone. But also, if you look closely, you may find that urethra is not moving smoothly. There is a kink in it. And maybe you can just see it. Here, there's a kink in that urethra, and that exists because the central to distal urethra is a lot more strongly tethered to the pelvic sidewall, or in this case, the pubic rami, the os pubis, rather than the bladder neck. So clearly, that area has a lot more freedom of movement. And this is why there's a difference in how much this area moves compared to how this area moves. And incidentally, this is the locus of pressure transmission. So you would have heard of the pubourethral ligaments, which are supposed to take care of pressure transmission and therefore guarantee continence. This is where it happens. And the location of this kink, this change in mobility, is associated with urinary continence, because if you have the further away from the mid-urethra that particular point of tethering is, the more likely is stress incontinence. Of course, you want pressure transmission at the location of maximum urethral closure pressure. That is where the muscle is strongest, so that that pressure transmission can enhance the intrinsic turgor or pressure, or the intrinsic quality of the urethra, which is highest at the mid-urethral level, which we know from urethral pressure profilometry, of course. Incidentally, this lady also has a true rectus seal. This is the anal canal, and there's a pocket, but we'll get to that later. You can, on 2D, there's another thing that's interesting. You can see the pelvic floor muscle. Oh, sorry. What we're showing here is a coronal view of the urethra in order to illustrate that tethering of the urethra that I talked about before. So this is a coronal view of the urethra with the external meatus here, the internal meatus of the urethra here, and these are para-urethral tissues in a coronal plane, which means there's the pubic rami left and right. The bladder neck would be up here, and the bladder is folded up and empty. And I think you can see that there are structures investing the urethra from laterally, echogenic structures. These can commonly be seen. It's just that they vary enormously in quality, in size, in elasticity, in bulk. And I guess one should make the point here that this is a part of the human anatomy that's undergone very rapid evolution. It looks very, very different in primates. It's another similar case. Again, a rather similar appearance. So there's these structures that tether the urethra. There's more here, and you can also see vessels there supplying the urethra here. Nobody's really done any decent research on this, and there may be quite a bit of opportunity for those who are looking for a clinical research topic. Now, what I've just shown you is really very recent, and we haven't really done much with that. But this particular slide was created in 2006, so it's a long time ago, almost about 18 years. And for all that time, we've had access to 4D transducers through the Avulsion systems, which were the first to implement that. And that gives us a multiplanar view. So these are transducers that have a curved array that oscillates. And in this case, it's 2.8 hertz, which means 2.8 times per second, you get a volume, a block of pixels or voxels, and that can then be shown in the 3 orthogonal planes. So this is the mid-sagittal, the A plane. So the symphysis pubis here, the urethra, the vagina, the anorectum with the rectal ampulla, and here is the anorectal angle with the levator in the back. In the coronal plane, you see the levator left and right as a drop shape or a sickle shape. In the axial plane, you can see the levator hiatus. The symphysis pubis is in front. There is the urethra, the vagina, the anorectum, and that's the puborectalis component of the levator. To see the pelvic floor, to see those structures even better, you can use what's called rendering. This is a method that was first developed to see baby faces. So this is a semi-transparent representation of the most important structures in the pelvic floor: the pubic rami, the symphysis pubis, the urethra, the vagina, the anorectum, and that's the puborectalis muscle, which inserts here on the left and here on the right. So we're looking into the bottom from below. One of the first things to check, and it's really, they tend to be in your face, they tend to be obvious, is urethral diverticula. They can take many shapes and sizes. This here is a small diverticulum that's filled with inspissated material, and that urethra is not normal either because it's got lots of hyperechogenic foci, which may be in some instances, the starting point of a diverticulum. And you can see how in all those images here, we're using the orthogonal planes. So the mid-sagittal, the coronal, the axial. Here, a tiny anechoic diverticulum in the mid-sagittal, in the coronal, in the axial. This is the most common, in my population, it's the most common form. So it's dorsal into the vagina, can mimic a prolapse, and it is pretty much in the midline. And you can see that anechoic cystic shape in the 3 orthogonal planes. This here is much, much more difficult. It looks multiloculated, but it's actually like a horseshoe wrapping around the urethra, and it's not even in one. It's kind of a double horseshoe in that there's some more here. And here in the axial plane, you can even pick up the tract, which is really quite obvious here. The main differential diagnosis is a Gardner cyst, and to distinguish a Gardner cyst from a urethral diverticulum, you need to look for the urethral rhabdosphincter. If the rhabdosphincter is okay, if that cystic structure is not breaching the rhabdosphincter, if the rhabdosphincter looks pretty much normal, then it's not a diverticulum, because diverticula tend to, at the very least, distend, if not destroy, the rhabdosphincter. Posterior vaginal cysts are another variation on the theme. It's just that they're situated in the posterior vaginal wall rather than the anterior. And again, you can see here's the rhabdosphincter, and that cyst is far away from it, has no connection. A skin gland cyst tends to be distal in the entrance in the external meatus of the urethra. They can be anechoic, but sometimes they're also hypoechoic, or there's some material seen within the cyst. Pessary pessaries can be a bit of a challenge in that there's so many different ones, but the salient feature always is that there is something that looks cystic. It isn't really just acoustic artifacts with reverberations behind it, as you can see here, and a leading edge that is what we call a specular echo, that is like a mirror And then the giveaway is these endless reverberations here. That's a piece of plastic that is that's reflecting 100% of the ultrasound getting to this point. So everything behind that is artifact. Bladder stones, depending on the climate that you work in the north of Brazil, is bound to be more common. This is a larger one with an obvious acoustic shadow. This is more like small, lots and lots of small bits of bladder concrements that may or may not throw a shadow depending on their composition. That's something you probably never see, a line running across the bladder here. I've only ever seen that once in my life. It's called pseudomembranous cystitis. And if you look in, it is as if the whole epithelium had lifted off. This is an obscure condition which may not even inconvenience the patient very much. Now, I've said before, there's some people who have a prolapse that takes a while to come down, and often this is a cystocele with an intact retrovesical angle, as it is here. So that's one of the standard forms of anterior compartment prolapse, and you can see here how we measure descent of that cystocele. Let's see what we've got here. So a valsalva, and there's something coming down between the bladder and the anal rectum here. This has to be the uterus. It's either the uterus or an enterocele. An enterocele tends to be isoechoic and like a snowstorm pattern. The uterus, as you can see here, is rather hypoechogenic. And sometimes you'll be able to pick up the endometrial stripe. So it's harder. In my experience, what I'm showing you here is a form of prolapse that is quite uncommon in Caucasians. It's very common in East Asia. That is an intact pelvic floor with a uterus that comes down like a piston. Such uteri tend to be retroverted, and the highest prevalence of retroversion we've found in Nepal on a field trip with over 60% retroversion. So their prolapse does not equal prolapse, and somebody who complains of prolapse symptoms in Gwangju or in Kathmandu is quite likely to suffer from a very different problem compared to somebody who suffers from prolapse in Porto Alegre or in Sydney. This is another clip to run. So the rectal ampulla is here, the bladder is here. There's quite a few prominent vessels in this area. Let's see what happens when she pushes. So the bladder's coming down quite a bit. She's very likely stress incontinent, okay? And there is what we call a true rectocele, that is a pocketed diverticulum of the rectal ampulla that herniates into the vagina due to a defect of the rectovaginal septum, which should prevent that in this area. A more complicated case here. So watch what happens with the anal canal, which is actually quite thick, unusually thick. But look what happens. Of course, there's a uterine prolapse. That's a small fundus that's retroverted. But look at what happens with the anal canal, and that acutely retroverted uterus almost looks like it's being pushed into the anal canal. So if the anal canal looks like that, it's an intussusception. It's a rectal intussusception. And if things are a bit worse, you may see this. So again, there's the anal canal. She does a push. That is enterocele. And this is enterocele flowing down the anal canal, which is a rectal prolapse, because that's what a rectal prolapse is. It is an enterocele that does not go down the vagina. It does go down the anal canal. Now, of course, normally we assess prolapse with the coordinates BA, C, and BP on the POPQ system. You can see associations here between ultrasound descent and clinical descent on POPQ. You can see there's very strong correlations. And there, of course, these relationships are all significant. But you can also see that the best association is actually for the anterior compartment. The central compartment is the poorest, which means that, and I should say that the central compartment uterine prolapse is the most commonly missed on clinical exam probably primarily because we don't give it enough time. So with ultrasound, you still see the tissues move, you keep watching. With a clinical examination, because all tissues move, we're not measuring relative to the symphysis pubis, we're measuring relative to the hymen, and the hymen moves as well, which means that you may not realize that those tissues are still moving downwards, that the uterus is still moving downwards together with everything else relative to the symphysis pubis, when it clinically appears as if everything stopped already. Now, the levator hiatus, the opening of the pelvic floor muscle, that central V-shaped opening, has become a first target for AI, for automated analysis. And about 10 years ago, a biomedical engineer from Belgium, Nico Sintwani, came to us to do training, and he then eventually produced this paper. This was about semi-automatic outlining of the hiatus. I thought this should be easy, but it's not. And to quickly give you an idea of why that is, well, of course, the machine can easily magnify the borders, the transition zones from dark to bright. Okay, and you can see that that's happened here. That's not good enough, because the machine is not going to be able to tell you which of these many contours is the important one. And what Nikhil and his team did is they introduced a gradient directionality condition, which means that the change from bright to dark was only processed or recorded if it occurred in a certain direction. That is from lateral to medially, from the periphery to the center of the image. And you can see here how then all the other contours disappear, and only those from periphery to center remain. And there you get pretty close to a contour. Now, there's been a lot of work done lately on this, both from individual units together with biomedical engineering units, and also by companies. This is something that Frida van der Noort did. This is a Dutch group, and we had her speaking just a few days ago at a webinar for Ayuga. So what this implies is the use of neural networks to determine the internal contour of the hiatus and to allow measurement of hiatal area. The basis for all this is a 20-year-old paper, nearly 20 years old, that we did to describe the methodology of measuring the hiatus. So this is about Valsalva here, and then we rotate the A plane anti-clockwise to make the plane of minimal dimensions horizontal. And then we look at the C plane like this. That can be done in a single plane like it is here. And I'm about to do the measurement. From 11 onwards, we've done it in rendered volumes after showing that that's actually quicker and likely more appropriate, because in particular in women with a larger degree of prolapse, if the pelvic floor muscle stretches a lot, the plane of the plane of minimal dimensions is no longer Euclidean. It's not flat. It's warped, because the levator doesn't just stretch sideways, it just stretches downwards as well, which means the lateral aspects of it that is here and there are actually further down than here and there. And that implies a warped plane, which you cannot measure in a single plane like that. It needs a rendered volume. There's other aspects where AI has become quite prominent. This is a video clip of an echocardiogram that records a cycle, one cardiac cycle, and then measures the fractional reduction or the movement of different aspects of the ventricular wall. So that kind of stuff's been around for quite a while, and now we're starting to see it in urogynecology. The first paper in this field was here from Zhang Jingling, a former trainee of ours in Guangzhou, and this is the result on two different machines, two different systems, two different strands of development. With the GE Voluson machine, you can see this is an automated analysis of the hiatus, and with such a clear volume, you'd expect an excellent estimate. So the automation says 24.82. I manually say 24.95. GE do that with you can see that it's a thick slice, and the operator has to place the line of the the plane of minimal dimensions, which is actually not entirely correct here. This is a mind ray volume in somebody with marked ballooning, much harder because she's got a big sister seal. You can see that is still a very good result from the automated measurement at 36.68, and my measurement was, the manual measurement was 36.45. So I don't want to say that AI always works for HIFL measurement. These are good examples. There's a whole lot that don't work so well. For example, here in somebody with a big sister seal, what the AI got it totally wrong here, because it didn't even recognize the anorectal angle here in the back. So it's not all. It's these systems are not quite ready for prime time, but they will soon be. The height matters a lot, because this opening of the pelvic floor muscle is the largest potential hernial portal in the human body. So the larger that opening is, the higher the probability, not just of prolapse, but also of prolapse recurrence. So this is 334 patients seen on average 2.5 years after the prolapse surgery in somebody with an avulsion and a hiatus of 40. In someone with an avulsion and a hiatus of 40, the probability of prolapse recurrence after 2.5 years was 80%. You can see the difference between those with avulsion, we'll get to that later, and those without avulsion who have a lot less recurrence. Incidentally, anterior compartment anchored mesh, these were periges and anterior prolapse. You can see that they make a huge difference in women with avulsion, and in particular if the hiatus is not entirely enormous. You can see the puborectalis muscle, the levator, on 2D. And what you do for that is you place your transducer in the midline and then swing it laterally in an oblique parasagittal cut. And you just imagine where that V shape of the levator is and then adjust your transducer accordingly. This is what a normal muscle looks like. And that's a typical full avulsion. So that's the muscle. This is the symphysis pubis, or the pubic ramus, really. And that's the side wall. So there's this triangular defect, which is very typical. That's the muscle that has been detached here, and you can see there's quite a bit of irregularity on both sides. Often there are big vessels, and the equivalent of that on palpation, of course, is that you just can't feel any muscle there, so it's a big hole. This is a clip using 4D View. 4D View is a software that is used to analyze volume data, and I'm here just going through the standard steps. So the patient does stomach contraction. We rotate the A-plane anti-clockwise by maybe 10-15 degrees. We then switch, and there's the plane of minimal dimensions from here to there. We then switch to the C-plane. We make the C-plane upright. We adjust all kinds of things to make it a bit clearer. And we make sure that the symphysis pubis is open here, closing here, closed over there at 2.5 millimeter interslice interval. And then it's really just a matter of either eyeballing. In this case, it's perfectly obvious that she's got a full right-sided avulsion, which is on the left side of all the images. But you can also measure the levator urethra gap, which is what we're doing here. Up to 2.5 centimeters is normal in Caucasians. This is something we did from 2007 or 08 onwards, and it's going to be very useful for AI systems, because they, using this particular approach, will be able to diagnose avulsion automatically, or at least provide a pointer to the operator that you should have a closer look. Now, what automated tomography can do so far is give you simply a series of slices. That is the system that's this is generated by Mindray. It's called a Smart Pelvic, and based on work that was done in Guangzhou by Zhang Jingling. That is the automated analysis, and that's my manual analysis. You can see the levator looks the same. It's just that the slices aren't quite in the right place. They'll have to adjust that. There's a misunderstanding of what the terms mean. This here is similar. Well, this is the GE system. It's called Sonopelvic, which does something similar with a slightly different approach. You can see that this is here the automated system, and it shows you a complete right-sided avulsion throughout. And this is my manual. So this is the other way around here. Don't get confused by that. This is the manual approach, which shows the same thing. Typical right-sided avulsion, where the muscle is disconnected, where that muscle is disconnected from the inferior pubic ramus. You can also see the damage in the coronal plane. So this is the axial, mid-sagittal, coronal, axial. You can see it in the coronal plane as well here, because there's a lot of muscle on this side, but there's really nothing there. This is where the pulpa rectalis, and higher up, I mean, this is already ileococcygeus there. We've known for a long time, from 06 or so onwards, and this is a major paper we had in the British Journal in 08, that avulsion is strongly associated with prolapse, in particular of the bladder and of the uterus. And this is another case of a complete right-sided avulsion. I should also quickly say something about imaging of the anal sphincter, and that is usually done by transrectal endoanal ultrasound, but you can do better with modern machines. You can do better with an exoanal approach by simply rotating your transducer from what we had before. So it's now crosswise, and it needs to sit perpendicular to the anal canal. So consider where that anal canal runs, because it's not running like that. It's running like that. With this kind of approach, in the A plane, you get the internal sphincter as a hypo to anechoic ring, and the external sphincter as an iso to hyperechogenic ring. Few tips and tricks: tilt your transducer at 40 to 60 degrees. Put one focus on as close to the surface as possible. Make sure you're at right angles to the anal canal. Lots of gel. You can never have enough gel. And then record a single loop of volumes during a pelvic floor contraction. Modify the pressure on the perineum during this acquisition, so that you can pick the volume that gives you the clearest view of the anal canal, and that would look like that. With the acquisition in a 3D 4D machine, this is the orthogonal view. So there's the external sphincter and the internal sphincter here. In the mid-sagittal view, which in this case is the B plane, because you've rotated the transducer, there's the internal sphincter, a dark stripe, and there's the external sphincter, a hypo to isoechogenic lozenge shape, a drop shape. Here in the axial plane, you should see the internal sphincter as a vertical stripe to make sure you're orthogonal. And then you switch to the tomographic imaging, and you get this kind of pattern. So there's the internal sphincter here. The mid-sagittal is our reference plane. There's that drop shape of the sphincter here and there. The time gain compensation isn't quite right, because this should be the same grayscale as this, so it's not quite right. But it's good enough, because you can see here in those 6 slices, you can see both the dark ring of the internal and the bright ring of the external sphincter. This one is supposed to be above the external sphincter, so it shows a defect which is artifactual, which is normal. And the lowermost of those slices should be below the internal sphincter, so that you do not see the dark ring of the internal sphincter anymore, because this slice is below the internal sphincter. So the top slice above the external, the bottom slice below the internal. And the giveaway here is not so much that, because that could change after childbirth. It could look like anything, of course. It is that structure, which is the fascial plane between the levator ani and the external sphincter, which has not been described prior. Has she had a tear or a cut? Well, she may have had both, of course, but there are distinctive appearances. This is a typical perineal tear. It's a zigzag, or like a tree root, which leads right towards the trauma, which is a 3B perineal tear that was repaired. So it's not particularly good. In this instance, this is what an episiotomy looks like. In fact, it's slightly unusual. The commonest appearance is a dark line like this, and this is one that was cut very well. It was started slightly away from the midline. It was cut quite shallow. There's an acoustic shadow behind it, and you can see here it almost looks hyperechogenic. That bright line. It's a bit unusual, because mostly these scars are hypo to anechoic. We can look at the adequacy of episiotomy, and this is a really bad one. The first thing is she's got a 3B perineal tear, which doesn't even look like it was repaired. I mean, it's wide open. This is how we measure a defect angle, as you can see there. It's over 100 degrees for most of those slices. But what's worse is there's an episiotomy which was started in the wrong place. It should have been started here or there. And then it was cut very steeply. It was cut so steep that it leads right to the sphincter. So this is how an episiotomy quite obviously can lead to a sphincter tear. So there's several problems. There's several breaches of professional standards. In fact, if the cut's that high, it suggests, if you can see it in the top slice here, that means there's a lot of tissue involved and the cut was really too early. So the episiotomy was cut too early. It was started in the wrong place. It was not cut properly. It was cut too steeply. And then it caused a 3B tear, which wasn't even recognized or repaired. So a total obstetric failure. We don't really need to go through this. AI actually, it does, is very soon, and to a degree it already does help with imaging of the sphincter, and I think there's a lot of promise in that in future. Mindray are already doing something like that, but it's not quite right because the interslice interval is so large that it covers the entire anal canal, and that leads to, artifactually bad looking slices up here. And also the other thing is they haven't managed to rotate the anal canal as yet to make it horizontal as it should be. So this is the automated, this is the manual. It looks very similar though, and you can see that there is a defect of the external sphincter. So in conclusion, pelvic floor ultrasound is commonly used in urogynecology now. It's easy to use, it's a low cost, patient acceptance is high, the equipment is increasingly everywhere, and of course there's no radiation and it's dynamic. I've shown you that we can assess the urethra and bladder both to document anatomical abnormalities and to document abnormal function. You've seen that ultrasound may be used to quantify pelvic organ prolapse, which is particularly interesting in situations where you don't quite know what's coming down, like in the posterior compartment where it could be a rectocele, a rectoenterocele, an enterocele, a rectal intussusception, or just perineal hypermobility. We can also image the anal sphincter and the levator ani for the assessment of childbirth-related trauma. We can assess obstructed defecation, as you've seen, and we can assess sling and mesh complications, which I haven't got time to show you today. Maybe we can do that at some stage in the future. And increasingly, and quite, of course, topical and interesting, is that AI is increasingly used to streamline workflow and to help with analysis. And over the next 10 years, we'll see a lot of movement in this particular area. Always, however, the operator is more important with ultrasound as it is with MR or CT. You're very much aware of that. And that means that the most recent machine and the best software is not going to give you decent results unless you're properly trained. And for the training, finally, a plug for the pelvic floor imaging online course of IUGA, which has had nearly 200 trainees now from all over the world. And we can provide preceptors, that is teachers that help people online and in interaction through 7 modules. And these preceptors speak 7 different languages. And this is where we come to the end. Thank you very much. I'm happy to take questions now.
Okay, thank you very much for your presentation. So I'd like to welcome Professor Dietz, who will be available for questions. And Lucas is also here with us to make sure we receive all the audience questions.
Hello.
Hello.
This seems to be working okay.
Yeah, I think so. Yeah, it's working fine.
So we've got, and Lucas, good to see you, to see your face for the first time. I understand, wir können nicht Deutsch reden, obwohl dein Name natürlich sehr deutsch ist, isn't it? But that's not so common in this house, not so uncommon in this house in Porto Alegre.
Yeah.
So, and yeah, Anzolch is, or Jäger is a very German name too. Okay, yeah. Never mind. I won't force you to disclose your German language skills. Now, do you have any questions for me?
Lucas, your audios are working. Lucas? Okay, I'll give Lucas some time to figure out his audio. Yeah, I think English is also always.
I just was telling that my old father would be proud if I speak in German with you, but I am not ready for this. And well,
my Portuguese is non-existent. I can do Spanish, but so I can read your newspapers, but I don't understand a word when you talk.
Well, first of all, I would like to thank Professor Dietz. It's a great pleasure for us. It's an honor your presence. I have talked with many people from Brazil, and they are present here because of you, because of your importance in the urogynecology around the world. And then, well, I am very happy with your presence here, and I would like to explore a little bit your presence to do some questions. I don't know if you have some questions to do in the chat, Marcelle, or can we do?
I think I can start. There was the first question we have is, I have been using both 3D convex and 3D vaginal probe for the bladder neck mobility and the elevator any muscle integrity. Do you see a difference in performance?
Well, the vaginal transducers are higher frequency, so on principle you get higher resolutions. But the big disadvantage is that they're an ergonomic nightmare because you have to hold this thing there all the time, and it's on the external, so it's not stabilized like a transvaginal scanner. The next thing is that I want the overview. I only have 5 minutes to do the entire scan, and that includes the sphincter and the levator. So, you know, I want everything in one go. And that's what I just showed you. Everything you saw was done with one type of transducer, and it can be done. The advantage of the curved array 4D transducers, which are used for abdominal or obstetric imaging, the main advantage is that it's got the whole pelvic floor. You see everything at once, and a volume that you save, or a scene loop of 4D scene loop of volumes that you save on using such a transducer allows you, you can look at anything. It's like an MR. You've got it all there, and then afterwards you can spend 10 or 20 minutes to look at everything. Okay, so you don't get that with a vaginal transducer. You can obtain some of the information, but you're too close to see the levator properly in a tomographic representation. It never really works properly. The footprint is so small, and the field of vision isn't wide enough. You'd have to kind of pull it out in order to see the levator at all. And the next thing is that you can't really do a prolapse assessment with a probe that's sitting there in shorts. People are unlikely to push properly, and so on and so on. So the only indication for a vaginal 4D that I could imagine is with a diverticulum, but then with a urethral diverticulum or with a sling complication. But that's, after all, usually sorted out with the abdominal probe. So I've got a transvaginal scanner here in the rooms I'm currently using, but I think it's years since we unpacked that. Okay, it's just not necessary. Any other questions?
Yeah, the second question is, for genuine stress incontinence without prolapse, it seems quite efficient that the ultrasound method for indicating a mid-urethral mesh surgery and to follow up the remaining mobility. Is it reliable?
Yeah. Just right now, this morning, I've seen the first two patients in the morning, and the first lady has symptoms of stress incontinence, but obvious DO and a strong urethra. So sometimes people have symptoms of stress incontinence, and it would be a very bad idea to put a sling in, because what their main problem is detrusor overactivity. Now, on the ultrasound, there will only be pointers. In this particular lady, there was no bladder neck funneling. The retrovesical angle was intact. Both argues against USI. If you're in a low resource environment, then I would say you could manage just with translabial ultrasound, but I would be careful in women with mixed symptoms, in particular if the detrusor, if the overactive bladder is predominant. If you've got somebody who leaks every time she coughs, and you do a clinical stress test and she leaks when she coughs, and she tells you she can't go to the gym because she's getting so much leakage, and then you put a scanner on and see the standard appearances of stress incontinence, which I've just shown you in the talk, then I would feel that you don't have to spend a lot of time, money, and effort to do urodynamics, in particular if the patient has to pay it herself. The issue of utility of urodynamics really is very dependent on the availability. So do you have access to such a system? Can she afford it? Or is it something that is hard to get, or is long wait list in the public system, that kind of stuff. And in that situation, in a lower resource setting, if you see the typical appearances of stress incontinence on ultrasound, sometimes I advise people to do a sling even if the urodynamics have been negative, because that happens in false negative. In particular, in young women with a strong urethra, you often see somebody who obviously has the symptoms and the appearance of stress incontinence, but we can't see it on urodynamics because her urethra is just too good and our challenges are not sufficient. Does that answer the question?
I think so. Yeah, I think it does.
Any other ideas?
I have another one. There is a question from Talita Martins. She's asking if are the ratios and evaluation parameters the same in the pregnant patients, or the overload on the pelvic floor by weight of the uterine pregnancy and other adaptation pregnancy?
During pregnancy, there'll be increased pelvic organ mobility. So, I mean, it's rare that in a multip you have to use a ring pessary to hold a prolapse up because it's so uncomfortable. And usually in a multip, prolapse is more symptomatic in the first trimester than later on, because the growth of the uterus basically pulls everything up. So the issue does not arise very often. Now, if you have somebody who's had a traumatic delivery and you are asked to give advice on a second birth, that's a different matter. The appearances of the levator or the sphincter are, if anything, a bit clearer, a bit more obvious during pregnancy because the tissues are more hydrated. So if you have somebody who's suffered bad trauma with the first birth, and she now wants to know whether she should have an elective cesarean, all I can say is most of the damage is done by the first baby. So the second baby is unlikely to do more damage. But then there are women, and I've seen one today already, who's got basically post-traumatic stress disorder because of a terrible pregnancy. And if that was the case, then of course she'll have, nobody's going to begrudge her an elective cesarean, is it? Regardless of what findings are. Now, if there's major damage there, then when it comes to the sphincter, if somebody's had a third or fourth degree tear in the sphincter repair, I think we're all agreed that a cesarean makes sense to protect the sphincter because it's been repaired. Now, the levator is never repaired. As far as I know, if there's anybody in Brazil who's tried to repair an intrapartum levator tear, they're quite uncommon to find because most of the damage is behind intact skin. So most levator tears are occult, as opposed to sphincter tears, which is why sphincter tears get fixed. And once they're fixed, you've got to repair to protect. That does not happen with a levator. The damage is done. Nobody's tried to fix it. And the likelihood of that damage to the levator to get worse with the second birth is really low, unless she has a forceps. Obviously, you got the message, stay away from forceps. It's the most dangerous thing we can do in obstetrics. And in future, already in Australia, there's a lot of litigation because we've got to stop. In Scandinavia, in Sweden, in Denmark, in large parts of Central Europe, Israel, Italy, Malaysia, there's lots of places around the world where there's very little forceps. But there are also places where there's still a lot of that done. For example, Australia or the UK in particular. Any other questions?
Yeah, I have another one. The ultrasound parameters can help to choose the surgery for physiotherapy or surgery for stress urinary incontinence. Is there any ultrasound parameter?
Yeah, well, of course. The combination of avulsion or no avulsion or intact muscle on the one hand, and hiatal ballooning on the other hand, gives an estimate, and I think I've shown you a slide, gives you an estimate of recurrence risk. And that means that in somebody who's got an intact muscle and a hiatus of 30, GHPB of 8, you just do your standard surgery. You do a vaginal hysterectomy, repairs, vault suspension if necessary, and the outcome's likely to be good. But if you have somebody with a GHPB of 11 and a hiatus of 50 and a bilateral avulsion, nothing you do is likely to completely fix that woman's prolapse. The probability of prolapse recurrence within 2.5 years would be 90% or higher. In somebody like that, you pull out all the stops. You send her to your worst enemy. I'm sorry, that was a joke. You consider a laparoscopic or abdominal vault suspension with extensions, with an anterior and or a posterior extension. You may also have to do work from below at the same time. Nobody really knows what's best in these women. In the past, we had anterior compartment anchored mesh, the perigee, the anterior prolift, which still actually fixed the prolapse in somebody like that. But you know what happened to the meshes, and I'm sure it's not that much different in Brazil. If you can still use anterior compartment meshes that actually work, then by all means explain to the patient and tell her there's an increased risk of complications, but there's also a reduced risk of recurrence. But we've had a lot of, in the Western world, we've had a lot of influence from activists on social media, which means that in Australia, nobody dares do anterior compartment mesh anymore, which is a pity. It's just ideological stupidity, which has affected urogynecology almost as much as it's affected obstetrics. But most importantly, you want a patient that's happy with you. And that means she needs to have realistic expectations. So if you just tell the patient, I'm going to fix it for you, and then there's a 90% likelihood of recurrence, and you can see that by simple clinical examination. You just need one eyeball and a ruler, okay? You get her to do a Valsalva, you measure GHPB, if it is 11, and if you examine internally and you find an avulsion, well, the likelihood of you fixing her prolapse is rather minuscule, okay? Mm-hmm. You don't even need a scanner for it. It's just that the ultrasound, because it uses our eyes rather than our fingertips, our sensory organs. The eyes are our top sensory organ, so it's better to rely on your eyes rather than on palpation, which is why radiology is a specialty of its own, and it's not palpatology. Okay.
Yeah.
So I think to make sure that the patient has a realistic expectation of outcomes, that's actually a major bonus. That is a big deal. That's good for your practice, and it's good for your patients.
I feel that pelvic ultrasound looks more documented for preoperatory, or I think it's more trustful than our physical exam.
Well, it depends. Okay, there's some people that can listen to a person's heart and come up with a correct diagnosis as regards her valves. Okay, but we're all different. Some people cannot do image analysis. There are some trainees, and I guess every radiologist, I have a radiologist with me right now, that's why I'm referring to her. Every radiologist knows there are some people who are really hard to teach. Same in surgery. We all know that. There are some people who you can't do anything with them because they're unteachable. Their hands don't work. Okay. So in some people, their eyes or their visual cortex doesn't work very well. It depends. Okay. Now, listen, guys, there's lots I haven't talked about because really you got the introductory. I'm happy to do something else for you in future on specific topics. So, slings and meshes, obstructed defecation, prolapse assessment, the levator ani, the sphincter, whatever. And then we can go into these matters in detail.
It would be great. But just the last question that I have marked here is, do you think there is a space for a role for the screening ultrasound, pelvic floor ultrasound after delivery? Or you have to choose a group of patients according to the tier?
Yep, this is what I've tried to introduce in neighboring tertiary units here. And frankly, 15 years ago, I thought it's a no-brainer. Everybody's going to do this. Virtually nobody is doing it because it's actually a big deal for obstetricians to accept that they're doing a lot more damage than they thought and that they need to adjust their practice. I mean, you heard me talk about episiotomy, the most basic of interventions, okay? And it's often just not done right, okay? Mm-hmm. Now, do the people who do the episiotomy want to hear about that? Do they want to hear about how much damage they do in labor ward? And it's worse with midwives. And in my world, midwives are not all powerful. They call the shots. They determine what happens. They've completely taken over in antenatal care and intrapartum. So this is why I'm not really that surprised that things are moving slowly, because there's just so much political resistance. If in an ideal world or in a private setting, what I would do, I'd suggest that first baby after the age of 31 or 32, big babies like 4 kilos plus, occipito posterior, malpresentations, forceps, vacuum to a lesser degree, these women, anybody with a lateral vaginal tear, anybody with a sphincter tear, they're all high risk for levator tears, and they ought to be assessed, and they ought to be motivated to do their pelvic floor muscle exercises, because that's pretty much the only thing we can do in the short term. And you'll validate their experience, because many of those women have had a really rough time in labor ward, and everybody says it's normal, it's childbirth, you'll be okay, it'll all settle down. Well, most of the time it doesn't. And it's a matter of validating their experience. It's a matter of showing them that somebody understands, that it's not in their head, and hopefully that they themselves can contribute to preventing major problems in future. But that's in an ideal world, and we live in a world that's very different, far from ideal. Okay, is that it for us? Can we close it? I think.
Yeah. We thank you very much for your time, and
you're very welcome.
And for next opportunities.
By all means,
I'm sure we'll have other opportunities, Professor. We keep in touch, and we'll have another invite for you. Thank you so much for participating.
And next time you'll have to try a sentence or two of German on me. Okay. Bye.
Bye.
Thank you. Boa noite a todos. Obrigada pela participação.
Boa noite.